Hello everyone, I am Dr. Snelata Verma from the Department of Orthodontics, School of Dental Sciences, BBD University. In this video lecture, we will talk about Class 3 malocclusion. Class 3 malocclusion is not as common as the Class 1 and 2 malocclusion. It is comparatively rare than the other two malocclusions. Class 3 malocclusion represents a pre-normal condition where the mandibular buccal teeth occlude in the mesial relation to maxillary dentition by the width of one premolar or more in extreme cases. Edward H. Engel in 1899 classified the malocclusion based on the anterior-posterior relationship of the jaws with each other as a class 1 malocclusion, class 2 or a class 3 malocclusion. So, according to him, class 3 malocclusion exists when there is a class 3 molar relation, and class 3 molar relation is the condition when the mesiobuccal cusp of the maxillary first permanent molar occlude in the interdental space between the mandibular first and second molars. So this is class 3 molar relation. So the class 3 malocclusion. In the class 3 malocclusion, along with the class 3 molar, there may be a class 3 incisor relation is also classified, which is according to British standards. Incisor classification states it exists when the lower incisor edges lie anterior to the cingulum plateau of the upper incisor. And in this situation, the overjet is reduced or reversed. And then again, after the Engel's classification, Davies modified his class 1 and class 3 malocclusion into different types. In Davies' modification of class 3 malocclusion, type 1 suggests when both the maxillary and mandibular arches are well aligned, it is supposed to be Engel's class 3 type 1. In type 2, there is a crowding of the lower incisors, and in type 3, Engel's class 3 type 3 malocclusion exists when there is a crowding or bunching of the maxillary incisors will be there. This is type 3 malocclusion. Hence, we can say a malocclusion, it is a malocclusion which is very, very easy to identify because of its extraoral features, but often difficult to treat, and it requires specific skill and enthusiasm of the operator to correct the malocclusion. So this is a skeletofacial deformity which is characterized by a forward mandibular position with respect to the cranial base and the maxilla. And the facial dysplasia can represent itself in the three ways, that may be due to the mandibular prognathism, due to the maxillary retrognathism, or the combination of all these two segments. If we talk about the prevalence in the different ethnic groups, in Caucasians it ranges between 1 to 4%. As I said, it's a rare malocclusion. In African American, the frequency may go up to 5 to 8%. While in Asians, frequency of class 3 malocclusion is somewhat higher because of a large percentage of patients with maxillary deficiency exists in the Japanese, Chinese, and Indians to different levels. So, what are the types of class 3 malocclusion? We can classify the class 3 into like a true class 3 or pseudo class 3 malocclusion. Whenever there is an underlying skeletal imbalance, that shows that will be a true class 3 malocclusion, and it is usually inherited by the parents. So it shows a strong genetic influence. Whereas the second type is a pseudo class 3, and pseudo class 3 malocclusion is due to habitual forward positioning of the mandible, and this may be because of occlusal prematurities or enlarged adenoids. We can also classify it, class 3 malocclusion in a different way, like functional, skeletal, or dental class 3 malocclusion. Functional class 3 malocclusion will exist when there is a abnormal tongue position, nasal or respiratory problems, neuromuscular condition that will lead to forward positioning of the mandible, leading to the appearance of class 3 malocclusion. Skeletal, as I said, It's due to underlying skeletal discrepancy associated with the maxillary transverse discrepancy and excess mandibular growth. In the dental, class 3 may exist because of ectopic eruption of maxillary central incisors. That is, they are in the lingual relationship to the mandibular incisors, or maybe maybe because of early loss of deciduous molars. The molar may come forward to represent a class 3 molar relationship leading to class 3 malocclusion. Coming to the etiology, what are the factors which associated with the as I said, it's a heavy, have a very much genetic influence, and most well-known example is the Habsburg family, that the Royal German family, having the distinct characteristics of prognathic mandible. As you can see in these pictures, they have a very prominent mandible with a prominent chin and typical concave profile, giving the class 3 appearance. Along with the genetic influence, there are some environmental influences are also there. Large tongue may be a reason to represent as a class 3 tendency. That is in cases of thyroid deficiency, which can contribute to mandibular prognathism by causing the mandible to be positioned forward all the times. Excessive mandibular growth could arise as a result of abnormal mandibular posture because constant distraction of the mandibular condyle from the fossa. And this is a picture due to premature contacts, that is anterior mandibular displacement of mandible due to premature contacts, which leads to reverse overjet. Acromegaly and hemimandibular hypertrophy are also the reason for the class 3 tendency. Acromegaly is caused by the anterior pituitary tumor that secretes excessive amount of growth hormone, and this excessive mandibular growth occurs, creating a skeletal class 3 malocclusion. And hemimandibular hypertrophy, again, there is a hypertrophy of the mandible, but only on one side, so leading to asymmetrical class 3. Teratogens causing cleft lip and palate are aspirin, cigarette smoke, dilantin, 6-mercaptopurine, Valium, etc. They may cause class 3 relation because of, as in the cleft, there is a maxillary hypoplasia or midface deficiency. So mandible, although it is a normal, but that will lead to a class 3 type of malocclusion. And vitamin D excess also causes premature closure of sutures, which may lead to class 3 malocclusion. As I said, cleft lip and palate results in maxillary deficiency and is associated with class 3 malocclusion. Features of class 3 malocclusion. There are distinct extraoral and intraoral features related to the class 3 malocclusion. Talking about the extraoral features, we will see a concave profile. Lips may be competent or incompetent. Chin will be prominent, and the lower facial height can be increased or decreased. Gonial angle can also be increased or decreased. Among the intraoral features, class 3 molar relation will be present. Incisor relationship in these cases may be normal or S to H, or an anterior crossbite occurs, that is called as reverse overjet will be there. Retroclined upper incisors and lower normal lower incisors may be seen. In the posterior segment, posterior crossbite may be there, and distinctly upper arch is narrow and short and lower arch is broad in class 3 cases. Diagnosis. The diagnostic procedure should help in the determination of the type of class 3 malocclusion. That is, we have to classify it, whether it's a dental or a skeletal, whether it's a true or pseudo class 3 malocclusion. So all the essential diagnostic records must be taken, and the study model radiographs that are must. Lateral cephalogram offers a valuable information for the skeletal nature of the malocclusion, that will tell about whether the discrepancy lies in the maxilla or the mandible, and how much amount of discrepancy is present there, we can calculate it. Clinical examinations should include observation of path of closure. It is very essential to determine whether it's a true class 3 or a pseudo class 3 type of malocclusion, and our treatment planning will be according to the type of problem which is there. In cases of asymmetrical asymmetries, if there is a jaw asymmetry, the PSF will be of give the valuable information that must be essential to show the amount of asymmetry. Along with the radiographic analysis, functional analysis is an important part of clinical assessment, and this will tell about the differentiation between the pseudo and true class 3. So, the path of closure from the postural rest position to occlusion must be carefully studied. The premature contact between the maxillary and mandibular incisors results in forward displacement of the mandible in pseudo class 3 malocclusion. So, as to disengage the incisors and permit further closure into the position in which the posterior teeth occlude. So, if there is a class 3 type of relation, but in the centric relation, the incisors come into edge to edge and there are existence of premature contacts are there. So, it is a pseudo type of class 3. How to differentiate? Mandible should be guided in a centric relation. This will reveal a normal overjet or edge to edge incisor relation in pseudo class 3. Okay. And the cephalometric analysis, pseudo class 3 malocclusion shows a normal SNA, that is maxillary base is normal, it's diagnosed early. Whereas SNB could be slightly increased because of forward positioning of the mandible. But in contrast to the pseudo class 3 malocclusion, true class 3 cases, where the true skeletal discrepancy exists, a large SNB or a small SNA. Large SNB will define the prognathic mandible, and small SNA will describe about the maxillary deficiency. So in true class 3 cases, a large SNB or a small SNA or a combination may exist. Most true class 3 cases have a strong hereditary component. If we see either of the parents, they have a similar type of jaw relationship, so that in that cases, it is most chances of being skeletal type of discrepancy is there. So, final diagnosis of the type of class 3 malocclusion relies clinically establishing the dual closure pattern by asking and guiding the patient to bite in normal centric and habitual positions. If in both the situation there is a forward positioning of the mandible and there is a skeletal discrepancy, this is a true class 3. But if there is a CRCO discrepancy, it is a pseudo class 3 type of malocclusion. For genetic influence, we have to observe the family tendency. Cephalometric parameters will say exactly about the problem. And incisor relationship, we can see what the overjet relation, whether it's a positive overjet or negative overjet, and accordingly we can plan our treatment. So cephalometric, if we again divide the class 3 malocclusion according to cephalometrics features, we have two things. Class 3 malocclusion, that is due to underdeveloped maxilla. So in that cases, maxillary base, we found a small maxillary base, length of the maxillary base is smaller than the normal. It may be positioned retroposition. There will be a smaller SNA angle because maxilla is point A is farther behind. SNB, that is a point on the mandible landmark. So normal SNB angle will be there. Mid-face deficiency will be evident, and in some cases, in cleft lip may be associated with that. Secondly, if this class 3 malocclusion is due to a strong mandibular base, that is problem lies in the mandible itself. So in that case, cephalometric findings will show the large mandibular base and ascending ramus will also large. In these cases, SN angle may be normal, SNB is larger than normal, ANB is negative, and in that cases, gonial angle is usually large. Articular angle is usually small, maxillary arch appears to be narrowed, The upper incisors, we see the upper incisors that will be shown as tipped labially, and the lower incisors will tip lingually as a nature's compensation. In that cases, lateral cross bites may also be evident. This is the most problematic thing when there is a combined underdeveloped maxilla and a prominent mandible. In these type of cases, cephalometric findings will suggest that there is a small SNA angle and the maxillary base is short, large SNB angle and the mandibular base is large. Here again the two conditions may exist with the patients which have a short ramus and a patient with a long ramus. In short ramus patients, the growth pattern is vertical and the gonial angle will be large. And these cases are mainly associated with the open bite. Whereas in the long ramus patients, here is the growth pattern is horizontal and then the gonial angle will be found small and reverse overbite is apparent because mandible is in the forward upward direction. Coming to the treatment options of class 3 malocclusion. What should be the objectives? Objectives must be to achieve growth modulation in the skeletal type of problem, to relieve crowding and produce the alignment of teeth, to correct the incisor relationship to obtain a normal overjet and overbite in these cases, and to achieve a stable molar relationship so that we had a good aesthetics and a functional occlusion. So what factors to be considered while we plan the treatment? According to our diagnosis and the problem list, factors will be the patient's opinion is must, what is the severity of the skeletal pattern, and what is the amount and expected pattern of future growth. As expected pattern of future growth, I mean to say whether it's a vertical growth pattern or a horizontal growth pattern, and what is the amount remaining or how much is completed, degree of crowding, as in if there is an edge-to-edge incisor contact can be achieved or not after the orthodontic treatment, and also what amount of dentovelular composition is already been there. So these are the factors which we have to consider during planning of treatment. Then coming to the early treatment of class 3. Most of the time it has been suggested that the class 3 malocclusion should be treated as soon as it is seen. So what are the rationale behind this? Early treatment for the class 3 malocclusion will prevent the progressive irreversible soft tissue or bony changes that will ultimately lead to the improving the skeletal discrepancy and also improve the occlusal function. So if we will be able to achieve these things, that will simplify our phase 2 comprehensive treatment. If we will be able to correct the skeletal discrepancy at a certain extent, then in the final phase of treatment, in the second, that is phase 2 type of comprehensive treatment, that will be much easier to go through. So at the early age, early treatment will also provide the more pleasant facial aesthetic to the patient, and there will be a boost up to the patient. So how to treat? Treatment of pseudo class 3 malocclusion, we have to remove the CRCO discrepancy, that is centric occlusion, centric relation must coincide. So for that if we will be able to correct the CRCO discrepancy, that will avoid normal wear and traumatic occlusal forces to affect the teeth, and that removes potential adverse effects on the growth of the jaws. Jaws will be facilitated to grow in a normal pattern, and it will establish a good functional occlusal balance and improves the facial aesthetics as well. Then if there is a skeletal or true class 3 exists, what are our modalities? We have basically 3 modalities: growth modification, orthodontic camouflage, and the orthognathic surgery. Growth modification procedures, as we all know, it can be done during the growing phase only, that is during the early mixed dentition, and orthodontic camouflage when there is a no growth remaining and we have to mask the mask the malocclusion as such. We will try to hide out the problem. And in orthodontic surgery, when the problem is severe and it is not, we are not able to correct it by the orthodontic treatment alone, then the role of the orthodontic surgery will come into the picture. Growth modulation procedures, we have two types of appliances. One is the myofunctional appliances, and secondly, we have the orthopedic appliances. In the myofunctional appliances, we have Frankel regulator 3, reverse twin block, class 3 bionator, and class 3 activator that can be used to correct the mid-phase deficiency and correct the class 3 malocclusion. Among the orthopedic appliances, we have chin cup and reversible headgear, and also the tandem appliance. Coming to the function regulator or FR3. This appliance is used during the deciduous, mixed, and early permanent dentition stages to correct class 3 malocclusion, which is characterized by maxillary skeletal reclusion and not the mandibular prognathism. So, and next is the reverse twin block. In this, we can also, this is used in the cases where there is a mild class 3 tendency. Is this class 3 type of twin block we achieve by reversing the angulation of the inclined plane. Whatever inclination is given in the class 2 to correct the class 2 malocclusion, that inclination is reversed back in the class 3 twin block, and it will do the correction of class 3, mild class 3 malocclusion. Class 3 activator, this is also given in the primary or early permanent dentition or mixed dentition. In the class 3 activator, the appliance is different from the typical appliance for the class 2 activator, as here it consists of a wire and acrylic parts. The wire component will be lower labial bow to stabilize the appliance. This is lower labial bow. Upper labial pads to remove the forces to the upper lip, and to create periosteal pull to induce the bone formation so that maxilla will be able to grow forward. And tongue creep may be attached to correct the anterior tongue thrusting habit, which is more evident in class 3 cases. Similarly, in the class 3 bionator, which is also helpful in class 3 malocclusion treatment in growing patients with mid-phase deficiency and reduced facial height. It causes mean increase in the upper jaw length, advancement of point A, that the correction of the maxillary base length, increase of the anterior facial height, reduced anterior-posterior mandibular growth. Come to the orthopedic appliances. We have chin cup, which is used in class 3 cases with a relative normal maxilla and moderately protrusive mandible. Because this will, chin cup will restrain the growth of the mandible. With the help of a chin cup, we can redirect the growth of the mandible. As we know, in the class 3, when there is a heavily growing mandible that will coming forward more as compared to the maxilla, so we can redirect the growth of the mandible. And there is a two types of chin cup, occipital pull chin cup and a vertical pull chin cup. In a vertical pull chin cup, the forces passes through the condyle. So there is a bodily movement, the face grows, the whole of the face will grow, but the chin is restrained. There is no growth of the movement in the growth of the chin. We can see in this figure, the face, the mid face is coming forward because there is no restriction and nothing, but the chin mandible is held by the chin cup, and there is no change in the second picture. There is no growth of chin. Chin is totally restrained. In occipital chin cup, the forces passes below the condyle. So in these cases, there is a growth of the chin in the downward and backward direction. Force magnitude and direction will be like force 300 to 600 gram per side 10 to 12 hours daily force is required to chin cup for chin cup, directed usually through condyle or below the condyle, as I said. It is given in the primary or early mixed period, mostly at the time of initial eruption of maxillary central incisors. And the treatment duration for the chin cup therapy may vary from the 3 to 16 months. Reverse pull headgear or face mask therapy, it is given in cases of where there is a mid-face deficiency. So reverse pull headgear will facilitate the protraction of the maxilla. It will take the anchorage from the forehead and the chin. So the use of face mask in the treatment of class 3 malocclusion was described more than 100 years ago. Here also, the extraoral force of 300 gram or more per side when applied can cause significant change in the circummaxillary suture and in the maxillary tuberosity. Tension produced within the suture was believed to cause an increase in vascularity and a concomitant differentiation of the cellular tissues, resulting in increased osteoblastic activity. Clinically, the maxilla can be advanced 2 to 4 millimeter over a 12 to 15 month period of headgear treatment. The use of protection headgear has also been shown to be the most effective in the full deciduous or early transitional dentition, with less skeletal changes after 9 years of age. As I said, as soon as we diagnose the class 3 malocclusion, as early as we should go for the early treatment of class 3 malocclusion. So among the different types of face mask, this is a type where it's a petit face mask where the main rod comes from there is only one assembly. Here is anchorage is taken from the forehead and the chin, and there is a one vertical rod where there is a provision for attachment of elastics at the clip level. This is a side view. This mask is known as petit face mask. This is a Delaire face mask. Here there is no single rod. There is a two rods that are coming from the side of the cheek. But anchorage also here is also taken from the forehead and the chin. And in between there is a horizontal bar which have the provision to attach the elastics. So this a heavy force of 300 to 450 grams at a 30-degree downward and forward to the occlusal plane is accepted and is minimizes bite opening. So while applying the face mask, we need a force of 300 to 450 grams at a 30-degree to the occlusal plane. See, here the line of force of action is downward and forward to the occlusal plane. We were talking about the elastics which will deliver the force from the intraoral assembly to the extraoral bar. There are different type of elastics that differ in their amount of force delivered and the size of the elastics. Here is the at the time of delivery of the appliance, 3 by 8 inch elastic which delivers 8 ounce of force will be prescribed for 2 weeks. Whereas after 2 weeks, 1 by 2 inch elastics, and the size of the elastics may be increased to a maximum of 5 by 16 inches. Young patients up to 4 to 9 years should wear the mask on a full-time basis except during meals, and the total duration of treatment is 4 to 6 months. While in older patients, it is worn at all times except during school. Along with the face mask therapy, rapid palatal expansion or rapid maxillary expansion is an integral part, because main goal of RME is to maximize the skeletal expansion and minimize the dental expansion. RME will facilitate the protraction of the maxilla by loosening the sutures which are present in the maxillary articulation. But when rapid heavy force is applied to the posterior teeth, there would not be enough time for tooth movement to occur. and forces are directly transmitted to the sutures, which open up with minimum tooth movement, and that will facilitate the protraction of the maxilla. And clinically, when sutures open, the width of the nasal floor and the roof of the mouth increases, and sutures will open in a hinge, like a hinge. They are more opening in the anterior posterior direction, separating more anterior and less in the posterior region. In this occlusal view, we can appreciate there is a more opening of the mid-palatal suture in the anterior region, which is gradually decreasing in the posterior region. And this loosening of the suture will facilitate our final treatment outcome of protection of the maxillary segment. Various type of RME appliances are there based on their methods of fabrication. There is a Hess type RME, rapid maxillary expansion appliance, which is a combination of acrylic and the wire component. Hyrex type RME, that is known as a hygienic rapid expander, where no acrylic component is involved. Here is only wire framework shouldered with the screw, and there is a combination where the acrylic splint type of RME, where all the teeth are splinted with the help of acrylic and joined to the screw. So this is a complete assembly of face mask which describes the acrylic splint over the teeth, so that making a unit of all the teeth, RME screw, and this is the buccal framework where a hook is made to engage the elastics, which will finally engage the elastics from the face mask assembly from the outside of the face. The region it is shouldered in the region of first canine and first molar region, and this is the outer face mask. Here we can see the elastics which are internally attached to the hook of this acrylic splint, and externally they are attached to the horizontal bar of this face bow. So what sagittal changes we expect after the maxillary protraction? There will be some maxillary advancement along with some mandibular rotation. So maxillary advancement, we are going to correct the maxillary deficiency, and the mandibular rotation in a backward and downward direction will also facilitate to reduce the appearance of class 3 malocclusion. Next appliance is a tandem traction appliance. It is more aesthetic and comfortable than the reverse pull headgear, because it is worn intraorally. There is no big extraoral assembly as in we have seen in the reverse headgear. For the appliance construction for this tandem traction bow appliance, here is an upper splint and a lower splint and a traction bow which can be modified from the face bow. The upper splint, which can serve the same function as a rapid maxillary expander, covers the palatal and occlusal surface of the maxillary teeth, and the lower splint covers the buccal and lingual surface of the mandibular teeth to reinforce retention. Orthodontic camouflage: proclination of the upper labial segment, retroclination of the lower labial segment, and combination of both. This is a figure of orthodontic camouflage when there is no growth remaining, and the protraction and camouflage was done by proclining the upper incisor segment and retroclining the lower incisor segment. Orthodontic surgery depends on if the severity of malocclusion is great. The surgery is advised when the value of A and B is -4 and inclination of lower incisors to mandibular plane is more than 83. Indications are in non-growing patients, cleft lip palate, and the facial asymmetries. Common surgical procedures involve Leafwood 1 maxillary advancement for retrognathic maxilla and BSSO setback for prognathic mandible. This is a picture showing the maxillary advancement surgery with the Leafwood 1 advancement, and this is showing the mandibular setback where a BSSO is done to correct the mandibular prognathism. Summaries: in the growing patient, we have to accept, or we can go for the functional or orthopedic appliances to correct the class 3. In a non-growing patient, we can accept the malocclusion if patient doesn't want to treat, and orthodontic camouflage can be done, or finally, if nothing can be done, orthodontic surgery is the option. Retention is very difficult. Applying a restraining force to mandible as from chin cup is not effective in controlling growth in class 3. Relapse from continuing mandibular growth is likely to occur, and such growth is extremely difficult to control. Early orthopedic treatment using face mask or chin cup therapy improves skeletal relationship, which in turn minimizes excessive dental recompensation. Maximizing growth potential of maxilla may minimize the extent of surgical procedures in cases of severe class 3 malocclusion. Thank you.